Hello, everybody. We are just about ready to get started. If you haven't already, you could take a minute if you are in the Zoom room to introduce yourself in the chat box. Let us know who you are, where you're calling from in Michigan. We have a couple people that are phone only here, so we want to keep you in the know as well. And yeah, I think we're going to get started. We are recording today's event for everybody who would like to rewatch in the future for anything that you learned about today. My name is Melissa Witham, and I work with C4 Innovations. We are a partner of SAMHSA's Opioid Response Network, and we are happy to be here today to talk more about changes and expansion of Medicaid reimbursement for alcohol use and opioid use disorders, and want to dive right in. Can you go to the next slide? So I wanted to take a few minutes to tell you about the Opioid Response Network, and then I'm going to turn things over to our main presenters. So the Opioid Response Network, as I mentioned, is a SAMHSA-funded, nationally scoped training and technical assistance center. Our goal is to support organizations and individuals and communities in their work with prevention, treatment, and recovery supports for people with opioid use and substance use disorders. The technical assistance that's provided through the Opioid Response Network is free of charge, so the people who request it. Next slide, please. And we work with local and national subject matter experts. They bring a broad range of experience and lived experience around prevention, treatment, and recovery. And each state has a technical assistance manager. So if you are interested, if you think your organization, after hearing this presentation, would like any sort of targeted training and technical assistance about the content that we're talking about, or about anything related to how you approach opioid use and substance use disorders in your work, you can definitely reach out. Next slide. This just tells a little bit more about the opinions that are being expressed today by our presenters are not necessarily the opinions of SAMHSA. Next slide. So to reach out to the Opioid Response Network, you can visit the website, or you can email us at orn@aaap.org. C4 Innovations is one of many partners that are part of this large initiative that we've been in. This is about our 4th year working on this initiative. We've made a lot of impact. Millions of people have received training and resources and information as part of the Opioid Response Network, and we are definitely eager to support your efforts as well. Next slide. So today we are going to, this is one of 2 webinars. So this webinar is kind of primarily targeted towards providers, a provider audience. We're going to talk a bit more about the Michigan Medical Services Administration's bulletin and changes to reimbursement for services around alcohol use and substance and opioid use disorder. So what we want to talk about today is just kind of talk a little bit about substance use disorders, just kind of a little bit of an overview, some of the data about the prevalence of substance use disorders, and then talk about a little bit about your role as primary care and different types of providers in your contact with your patients, and ways that you can help impact substance use disorders in your area, and then talk about those changes in Medicaid billing. And then in our second webinar, which will be in a couple of weeks, we're going to get it a little more into the nitty-gritty about the billing and some of the common billing errors that people have experienced. And really, we are interested in your questions. So throughout this presentation, we're going to be sharing some information with you. You can post your questions anytime in the chat, and we will gather all those questions up, answer as many as we can before our time is up today. And then we will write out answers to those questions and make those Q&A documents available to folks who attended, so that you'll have those for your use in the future. Next slide. And with that, I'm going to pass this off to Dusan, and he's going to take it from here.
Thank you so much, Melissa, and thank you, ORM Network, for putting this together, this webinar. Today, besides me, my name is Dusan Stojicic, and I'm Associate Director at the Substance Use Disorders and Justice Involved Population at Community Catalyst and Opioid Response Network subject matter expert. I'm delightful that Laura Kilfoyle will join us from Michigan Department of Health and Human Services Bureau of Medicaid Policy, Operation, and Actuarial Services, and Dr. Cara Poland, who is a board certified addiction medicine physician and assistant professor at the Michigan State University College of Human Medicine. Just a quick reminder before we start, we will have, as Melissa mentioned, session 2 on December 2nd at 10 a.m., where we are going to review this policy, discuss particular aspects of the billing and common billing errors and how to avoid them. And this session is really targeted toward administrators who handle billing for provider practices. With that in mind, I'm passing it to Dr. Poland.
Hello, I think many of you know me. I'm Cara Poland. Thank you for the introduction. This has been a bit of a passion project for me, expanding this access and working with Medicaid to make sure that we have the most access for care for people that have a substance use disorder, so that there has been coverage for some services through opioid use disorder. We're going to learn a little bit more today about expanded billing codes for opioid use disorder, as well as new billing codes available for the diagnosis of alcohol use disorder. Go on to the next slide. We're here because we know we're in an epidemic with substance use disorders. I'm sure most of the folks on this call probably saw the data that came out from the CDC yesterday. So we surpassed the 100,000 opioid-related deaths mark in the prior 12 months as of April of 2021. And so that's why this is so important to me. And I know at least part of why it's so important to everyone on this call. So first, I want to thank all the providers out there that are treating people with a substance use disorder. And hopefully this will make access to that care more available to patients. As we all know, substance use disorders are chronic illnesses that we often use the MS sort of relapsing remitting language with substance use disorders, and having the ability to see providers and have us be able to be reimbursed for that care is hopefully going to increase the access. The purpose of this is so that individuals outside the PIHP services can have a way to bill, and we will go into the details of what that looks like. But this is intended for primary care offices to be able to bill for treating people with a alcohol use disorder or an opioid use disorder in that primary care setting. Move on to the next slide, please. Here are some of the statistics. Part of why increasing and adding alcohol use disorder was so important. I am trying to force my voice. I have a little bit of laryngitis. If it gives out on me, I apologize. Is because of the just sheer numbers of people that are affected by alcohol use disorder and opioid use disorder. I'm very public about it, but this is really near and dear to my heart. My brother died of an alcohol use disorder, so the work that we do is just so very, very important. And obviously, we all know that we're in the middle of a opioid overdose public health crisis with, Michigan has not been spared that. Michigan has increased 10 times annual overdose deaths in the last 20 years. And as we all know, the majority of people living with alcohol use disorders and opioid use disorders are not getting treatment. Less than 10% when we really look at both alcohol and opioid use disorders. We can see on the slide 7.2% of people with alcohol use disorder reported receiving treatment in 2019. Unfortunately, that's actually declined. So we really, I think this policy would really help us make some good strides. I like to tell people that it'll be pretty easy to get some improvement. And if we can lead that in Michigan, with our Medicaid population, I think that would be remarkable. Next slide. I think I have one more. Yes. We know that this is totally doable in the primary care setting. We have FDA approved medications to treat both alcohol use disorder and opioid use disorder. And the state has removed prior authorizations for the vast majority of these, making them easily accessible in a timely fashion to prevent risk to our population of overdose death due to any delays in care. So that's been a huge change that I'm so very thankful for. And I'm going to turn it over to Laura Kilfoyle, who's going to be able to tell us a little bit more detail about the exciting expansion and coverage. Thank you.
Great. Thank you so much, Dr. Poland. Appreciate so much being able to come and talk about this policy, which is MSA 2119. I am Laura Kilfoyle. I work for the Michigan Department of Health and Human Services in the Medicaid Policy Division. Our administration has also been renamed recently. We were Medical Services Administration. We are now the Health and Aging Services Administration. So just a bit of a note there, this is a new development. Our director wanted to consolidate aging services within Medical Services Administration. So we created a more hybrid sort of department. So I just wanted to make sure I pointed that out. We are now the Health and Aging Services Administration. So if you see us referred to as MSA, that is our beloved older name, but we are now HASA now, which we have affectionately started calling it. So this has been a great journey for me, and Dr. Poland has been such a great partner with us, working through how we can more effectively provide reimbursement opportunities for providers who are serving our population, because obviously, as she just so accurately pointed out, there's so many people suffering with these disorders, and this has been a really great opportunity for us to partner with her and to partner with all of you to see if we can help expand reimbursement. So if you could go to the next slide. So the policy itself is MSA 2119, and you may recall, if you've been around for a while, there is an older policy called MSA 1556. And MSA 1556 was our first kind of dip in the toe of office-based opioid treatment and offering a fee-for-service mechanism for reimbursement for that policy. So that policy went into effect it went into effect in January 1st of 2016. And like I said, it was our first kind of go out there and say, we see that there is a concern out there. We see that there are many people who need care. And obviously we want to encourage folks to receive care within our specialty services behavioral health system. So that is within the PIHP or CMHSP system. But we understand that many people go to primary care regularly. Many people share things with their primary care provider, and there are many primary care providers out there who could effectively be able to treat these disorders. So exactly as Dr. Poland mentioned, there are lots of mechanisms to be able to treat these in a primary care setting. So we launched that initial policy, again, MSA 1556, and that kind of sat out there for a few years. So as you saw, we have been talking about expanding this policy and updating this policy for quite some time. Unfortunately, we got derailed by a little thing called COVID for a little while. So that kind of put us off track just a bit, but we came back to it again with the help of a lot of input from stakeholders to create this new policy, which did go into effect on August 1st of 2021. So we are now 3 months into it. And I'll just kind of hit the highlights of the policy. I definitely encourage you to take a look at it in your free time. I realize I'm a policy wonk, so I really love this stuff, but we really tried to be as concise and as deliberate as possible within the policy itself. I will say that we got a lot of public comment on this policy. We incorporated so much into it, and yet we still wanted to make it as concise and as clear as possible. So we tried to take the very best of what we had in our old MSA 1556 to kind of pull out the best of it, to put it into this new policy and expand it. So the first thing that I always want to hit on is that, this policy was created to offer an additional, a reimbursement mechanism outside of the PIHP, CMHSP system. And when I say outside, I in no way am trying to, say that we want to divert the PIHP, CMHSP system, because obviously that system exists to serve people who have severe disability, severe illnesses and severe opioid use disorder and alcohol use disorder. And there are many times when folks need those more intensive services that the PIHP, CMHP can provide. So, our goal with this was just to offer a no wrong door approach, was to give primary care the opportunity to effectively, which we know that they can effectively treat these, but then to be made whole and to be reimbursed for those services. So we always like to point that out. It's not in any way trying to, take that system out and not use that system. It's instead offered as a no wrong door approach. Folks go and talk to their primary care provider about a lot of things, especially with a lot of the work in social determinants of health. So we definitely wanted to provide a mechanism for those providers to be made whole. Another thing that I always like to hit on with this policy is we tried to be as specific as possible with the types of diagnosis codes and the types of procedure codes that could be billed with this. We always walk a fine line with that, because as a payer, we cannot tell people, and we do not tell people, it is not ethical, it's not right for us to tell people how to bill for services, right? There's billing is out there. We encourage providers to provide the services that are medically necessary and appropriate for their beneficiaries, but we try to really provide as much information as possible so there wouldn't be any confusion about the types of services that can be reimbursed because of this. So we really did spend a lot of time trying to ensure that that was built in there as well. If you could go to the next slide. So as far as the actual expansion of services, so what this policy does is it allows folks that are primary healthcare providers to submit claims for services rendered to beneficiaries who meet the ASAM criteria for outpatient treatment within a primary care facility, and then based on their diagnosis within the ICD-10. Okay, so there's a lot there. Let me unpack it a bit. So the first piece of it is the phrase primary healthcare provider. So we went through and we put in a lot of language when we first did the draft of this policy that called folks primary care providers, right? Because it's a primary care provider. I go and see a primary care provider. That felt like a pretty big umbrella. Unfortunately, that created some confusion in the field because folks immediately thought, okay, does that mean my MD? Does that mean my, what exactly does that mean? So we went in and we specifically defined that within the policy. And there's an actual slide coming up, and we'll talk about this a little bit more, but I did want to make sure that we called that out because it's not just a primary care provider. There are many providers who could be reimbursed under this policy. So that's the first part of this kind of unpacking of this definition. The next one is the ASAM criteria. So obviously, appropriateness for treatment within an outpatient setting should fall under that ASAM criteria for outpatient treatment. That is something we had in the original policy, MSA 1556, 5 years ago. It was something that came through again. Folks really thought that that was a very appropriate way of determining who is appropriate for service within a primary care setting. And then obviously the diagnosis codes in the ICD-10. So we use the ICD-10 for all of our billing and coding, and everybody who submits things to us uses the ICD-10. So that ICD-10, before within our old policy, we had some of the diagnosis codes covered under opioid use disorder and alcohol use disorder. We didn't have all of them, and that created some confusion. And folks said, well, wait a minute, I don't understand. What if they have a diagnosis of opioid use disorder, but they don't have a diagnosis of opioid abuse disorder, or what are those specifically? So we tried to rectify that within this policy as well, which is we are covering all of the codes within the ICD-10 under alcohol use, abuse, and dependence, and opioid use, abuse, and dependence. So this reimbursement expansion is designed to focus on services for patients of all ages. And again, they're patients who do not need specialty care. So they're not folks that need to be referred to the PIHP, CMHSP system to receive those extensive services that they can provide. These are folks who can be effectively managed within a primary care setting. And they obviously, as we stated earlier, they can be managed there as they would for any other chronic disease. Now, I will say, if there comes a time when a patient obviously moves beyond what could be provided within a primary care setting, our expectation would be that a referral would then be made to the PIHP system. And again, that's also represented in the policy. I'm sure you're all aware of this, and any disorder or anything where you refer to a specialist as needed. So that piece is always within the policy as well. Next slide, please. So patients who qualify, so again, these are Medicaid beneficiaries, so they have to be our beneficiaries who are enrolled in Medicaid. And their primary diagnosis is, again, you're going to see these words, opioid use, abuse, and dependence, or alcohol use, abuse, and dependence per the ICD-10 diagnosis codes. So again, this was our attempt to be very clear that we are covering all of the diagnosis codes under alcohol use and opioid use. So when you look at a diagnosis book, you'll see that there are specific things like the F11 is opioid related disorders. And then under F11, there's all sorts of disorders. There's use disorders, there's abuse disorders, there's dependence disorders, and they're all listed underneath there. So it's like F11 dot something. So for example, like F11.1 are opioid use disorders, right? And then after that, there's .1, and then there's more numbers after that. We went ahead and said, okay, we're not going to parse out specific diagnosis codes. We're just going to say we're going to cover them all. So if you have an opioid use, abuse, or dependence, or an alcohol use, abuse, dependence, diagnosis, then this policy covers that beneficiary. So again, just trying to make that very clear, just trying to make it a lot easier for folks to be able to say, okay, this is their primary diagnosis. This is what needs to be on the claim, is one of these alcohol or opioid use, abuse, and dependence. I will point out too that we use the language use, abuse, and dependence for the ICD-10. And I realize that that might not be the best language when we come through like person-centered or patient-centered terminology. I'm not advocating that we call any of these things to actual people, but I'm actually, it's just easier as we use the ICD-10 to keep the language the same to actual diagnosis codes that are in that ICD-10 manual. So I definitely understand that those are things that we don't necessarily want to use specifically with our patients and to use those words with them. However, it just makes it so much easier when we try to be clear about what it is that we are reimbursing for. So I did want to point that out. And I know that folks have definitely made comment regarding that. We totally hear that. But this was our best way to actually, make it as clear as possible when submitting, when providing these services and submitting claims to us. So this reimbursement expansion opportunity is designed to focus on services for all patients. Oh yeah, we talked about this. Doesn't need specialty care and can be effectively treated. And they don't have to be previously diagnosed with an alcohol use disorder, opioid use disorder. That diagnosis can happen at the office-based visit. So again, as you're working with patients, as you're asking those questions and getting information about them, if they disclose this and this is a diagnosis that's appropriately assigned, then that's something that we would cover under this policy. So next slide, please. So who can bill for these services? So these are just examples of licensed providers. And again, if you look at the policy itself, the bottom of it really lists all of these out. So these are specific licensures, specific areas, specific people who can bill for these types of services. And you'll know we put the physical health care provider examples on the left-hand side. So these are, obviously physicians, NPs, PAs, and those sorts. But we also included behavioral health examples here. And those are psychologists and social workers, licensed marriage and family therapists. And it was really important for us to be able to kind of connect primary care to these types of providers if appropriate. We understand that not all providers will have a licensed psychologist within their practice or anything like that, but we wanted to open this up as an option. And we also obviously give these types of providers the option of servicing beneficiaries regarding that as well. So just a few other things on the policy. Again, I definitely encourage you to take a look at it to see if they're, to see the other details that are in there. Wanted to point out again, and I think Duchesne's going to talk about this in just a second, but the types of services that are covered, we did specifically outline those in the policy based on the current CPT and HCPCS codes. So definitely take a look at that. I will tell you though, that as new codes are introduced, there could be other codes that are included under this policy. They would go on our physician fee schedule. So that creates, it's a little bit harder when you put out a policy that's in the specific time that you're putting it out, because obviously, as we all know, CPT codes and things like that change. So definitely keep an eye on the our provider fee schedule, and I'm sure that we'll go through more of that in our next billing session on December 2nd. And the last thing I want to point out before I turn it back over is, there's really a section in there regarding the continuum of care. So we firmly believe that there are many people who can be effectively treated within a primary care setting for these types of services. And we want to make sure that we open the door for that to increase access to services. But there are also folks who may need to be referred out. So that PIHP CMHSP system is definitely there. It's definitely something that should be utilized if a beneficiary obviously needs more more complex or more extensive services. So I definitely wanted to point that out. Just one more thing. I know I said that the last one was my last one, but here I go again. If you have comments or feedback, obviously we are always here for any of those. Like I said, Dr. Poland has worked side by side with us on this policy and really helped us work through it. We are always open to feedback and to just suggestions regarding the policy. We never want to create something that doesn't make sense in the field. So we encourage folks to email us, let us know any comments or suggestions regarding that. So I think I'll go ahead and turn it over.
Thank you, Laura. And thank you so much for being so engaged and involved to make this policy as specific as possible. As someone who is coming from a national organization, I can say that definitely in Michigan, you guys are doing a great job. So thank you for that. And when it comes to type of services which are kind of covered under this policy, starting from a basic one of evaluation and management and consultation services, and then psychotherapy services. Of course, if there is a specialty or not specialty, if there is a staff who is available to provide that kind of services inside of your primary care or inside of the office-based unit. And then care management services, including psychiatric collaborative care management, but also behavioral health care management services, and as well as screening, brief intervention, and referral to treatment, which we'll we will talk a little bit more later on. And the most important, maybe the most important one, is medications for treatment and of alcohol use disorders as well as opioid use disorder services, because it is important, especially during this time of COVID, that everyone has appropriate access to treatment and quick access if necessary. And finally, drug testing and all the other laboratory services who are coming together with the policy. So having that in mind, since my background is a health economist, I was trying to kind of put together how this would look like based on the example of screening, brief intervention, and referral to treatment. So when you're billing to these services, as Laura mentioned previously, you're assigning appropriate ICD-10 code for opioid use disorders or alcohol use disorders. If it is F11.XX or F10.XX, and then after that, there are a couple of codes who are coming under the screening, brief intervention, and referral to treatment services: 99408, 99409, G0396, G0397, G2011. And there is a sort of inside of this policy, there is a requirement that you need to use validated screening instrument, such as alcohol use disorders identification test or audit, or drug abuse screening test or /DUST, in order to provide these services. And finally, codes like 99408 and 409 can be added to other evaluation and management codes for our office or other outpatient services as appropriate. And having that in mind, what is the connecting with the patients early, how can that improve their outcomes? And I need to say that from my personal perspective, beside the fact that I'm a health economist by training, I'm also a person with a lived experience of substance use disorders, successfully in recovery for the last 13 years. And I need to say that my first kind of a touch, and the first time I spoke openly with someone in order to start to treat my disease, was with my primary care provider. So having that in mind, how this really helping patients. It's helping patients who are ready to engage, who are not ready to engage in alcohol use disorders or opioid use disorders treatment, such I was, where because of the stigma or the various thing, or they're just like scared, and really having that first touch and first connection with your primary care provider, well, trust is already built, and you already, that's a person who are you already seeing at least once a year regularly. It's essential, and it's really it really can save lives. And I this is not my intention to put the burden that all of the providing services and everything is just on primary care providers. It's really intention to kind of a deep your relationship with the patients and really be curious about how they're feeling, and kind of enable them to open themselves so they can receive appropriate treatment. And having said that, every visit is actually a chance to help the patients to being healthy, to go through the healthy changes and move toward treatment and recovery, such as in my case. And finally, this is a really great opportunity for society to prevent opioid-related overdose, which is, as Dr. Poland mentioned at the beginning of this call, it's skyrocketing nowadays. So this is just, but again, it's not trying to put the burden on the primary care providers. This is just one piece of the puzzle we need to do all together in order to move into that direction. And having that in mind, I'm opening this for you if you have any questions, and maybe Melissa, if there are any questions coming from chat.
I don't see questions, but I wanted to point out that anyone can unmute themselves. So if you're here phone only, feel free to unmute yourself and ask your question.
Laura, I was wondering if you could speak a little bit to kind of the unique way that we bill for these services, and what comes to the state, what comes through CHAMPS, and what goes to people's Medicaid HMO product.
Yeah, so the way that we wrote the policy is if a provider currently has an arrangement with a Medicaid health plan to provide these services, then stick with that. We do know that there are some nuances in Michigan where folks may have a specific relationship with a Medicaid health plan. That Medicaid health plan might be paying for that. So stick with that if that's the case, right? If that's not the case, then it goes through our fee-for-service reimbursement mechanism, which is essentially, and a lot of this I think will be covered at the next one, but it's enrolling in our CHAMP system as a provider and then billing us, the Michigan Department of Health and Human Services, directly for these types of services. So on that, the claims would have those diagnosis codes we've talked about. So F11.XX or F10.XX for alcohol use disorder or opioid use disorder. And then the specific service codes that are represented in the policy as well. And that then would go directly to us, and then we would pay those directly to the provider. So it provides a different mechanism, a specific, we call it fee for service or direct billing to the department for these specific services. And again, we're hoping that creates an extra avenue. It's interesting, when I was listening to Dushan, I was really appreciative of his story and everything, because we were seeing a lot of these claims and encounters come through our system where primary care was doing a lot of this work. And so part of it was like, we just wanted to make primary care whole. We wanted to make sure that these services were not being done. I mean, we appreciate that providers are willing to render the services that are needed, and that's absolutely amazing, but we also don't have the expectation that you're going to have to do that for free. We want those to be able to be services that are that we can provide reimbursement for, and we realize our reimbursement is not the best as ever, but we want to provide what we can to do that. And I'm so appreciative of primary care having those discussions and conversations with beneficiaries, because we know that those lines of social determinants of health and all of that, you know, people share with their primary care. I know I share with my primary care. I mean, it's you know, it's an avenue where, as Dushan mentioned, there's not really stigma going to a primary care provider, right? There's all these like natural things that folks naturally speak to those providers. We want to make those providers whole and encourage treatment for those types of services. So yeah, we're happy to do this. We're really excited to see kind of where, you know, the expansion goes and whether, you know, the numbers that we're going to start seeing because of this. And we just thank providers for being willing to do it.
This is Tim Gammons. Thank you, by the way. Very informative. Really appreciate it. I do have a question. I'm a doctor. Our biller is on this too. And so are there any, I guess the question is, if we in practice have issues with the nuances of billing, what and who would be the best way to get questions answered?
Yep. So we actually have someone going to call Nicole, who works for our provider support area. And there's kind of a general email to provider support. And I know sometimes emailing a general email is not helpful. I will say in this one, though, provider support is able to get that and determine who needs to address that question. So it's Nicole, make sure I get this right, provider support at MDHHS.
Nope, it's actually provider support at Michigan, all spelled out, .gov. Anyone on that at the email address can answer your question. We usually turn emails around within 3 to 5 business days. If need be, your email will be moved up the chain to someone who can help you a little bit further. In order to answer any specific billing questions, we do have to have an enrolled NPI in CHAMPS. If we don't have that, we can send you out to our Medicaid provider webpage, which is www.michigan.gov/Medicaid providers with an S at the end. Out on that website, you will see billing and reimbursement, which is our Medicaid fee screens. You'll see the Medicaid provider manual, any alerts that we have posted regarding system issues, system downtime, provider specific information, how to enroll in CHAMPS to become an active provider. There's actually step-by-step tutorials out there on how to bill CHAMPS, including if other insurance is necessary. So that's a very useful tool as well. You can call provider support as well at 1-800-292-2550. That is our call center. So personally, I think email is a little bit better of an option. And if you would wish that one of us calls you back, just put that in your email. And one of us will pick up the phone and actually call you and walk you through any questions that you have. Provider support also gives out one-on-one training appointments. So you can request a one-on-one if you go to that michigan.gov/Medicaid providers webpage. There's recorded trainings out there as well. We actually just did a physicians and behavioral health training on Tuesday. So that recorded training is out on the website as well. We're currently, I don't believe that they sent out the FAQs from that presentation yet, but that's out there as well.
Okay, could you tell me, because again, I'm a doctor, I'm not a biller. Is it dramatically different than billing the HMO Medicaids as might be traditionally done?
No, the HMOs actually should at least follow Medicaid policy and billing rules. They can add a little bit of their own requirements as well. But billing Michigan Medicaid is the fee for service side should pretty much mimic what you're billing the managed care side.
So are you saying that if we're already billing, let's just say Blue Cross Complete is something that we apparently have had issues with when we're using behavioral health diagnoses. If we're billing Blue Cross Complete right now, right? If we're already doing that, is that all that we need to do to get this reimbursement? If we're not getting claims paid, do we need to do something beyond what we're already doing by billing Blue Cross Complete?
So if the beneficiary has Blue Cross Complete and you are participating with Blue Cross Complete, are you talking like the Michigan Health Plan Blue Cross? What, or is it a commercial?
No, Michigan Medicaid. That's
Okay.
the name of Blue Cross is Medicaid. I think the term's HMO.
Okay.
But yes, called Blue Cross Complete.
Yep. I just want to make sure that we were on the same page. There's a lot of different ones out there. So just so we're on the same page. Yeah.
Right.
So continue to bill Blue Cross Complete. If you're not getting reimbursement from them, you can always contact that provider support at michigan.gov. We can try to get a managed care like consultant involved on the state side to contact Blue Cross Complete for you. But if the beneficiary has fee-for-service and you are enrolled with fee-for-service, you have an active MPI, you've enrolled in CHAMPS, the whole 9 yards, then that could also be an option as well if the beneficiary has fee-for-service. So there's multiple different ways that we could go about this. If you would like, you can email provider support and I can get your information from this presentation and just look for your email coming through. And we can talk on the side too. And I'd like, they said there will be a billing presentation that we do put on where I will be presenting some of the fee-for-service billing as well. And I believe that date, correct me if I'm wrong, is December 2nd.
Okay, we'll probably send you an email.
Okay.
And then my last question is, you said that the prior the prior conference, that's on the michigan.gov/Medicaid providers.
Yep, that
You said,
that one was given on Tuesday from MDHS provider support. And that one is at the michigan.gov/Medicaid providers webpage. If you scroll down and go to training, click on that training tab, scroll probably to the bottom of the page now. You'll see, I believe it's called Physicians in Behavioral Health.
okay, great. Okay, thanks again. Thank you, Cara, too. Great job, everybody. Thank you.
The other thing that often happens is we're in primary care is just somebody who comes in and they don't come in with just one complaint. They come in with, they have diabetes, they have an alcohol use disorder, they have hypertension. And so in somebody that has more than kind of just behavioral health, which I have to imagine is often the norm, are we to build the HMO product or are we to build the fee-for-service?
Yeah, so this is where it gets tricky. So what we say is that the primary diagnosis is what drives it. So if the physician determines that the primary reason that they're there is for an opioid use disorder, alcohol use disorder, then they would bill this policy, fee for service for those services. If the primary, and I realize there's a lot of gray here because people are not like in these, very specific lines here of diagnosis. I totally get that. But if their primary diagnosis is something physical health related, then they would bill that because that's covered under the Medicaid health plan. So we always say it drives like the main reason that they're there. So that's obviously provider discretion, as far as what the main reason that person had that visit. So that's how
Yeah, I think that's important to point out because you don't have to make a separate special appointment for your patient to come in just for their OUD so you can bill through CHAMPS through fee for service. You can have, when they come in, you can do what you do well as primary care doctors, which is take care of a variety of concerns that person might come in with on that given day. And what we always have to pick a primary diagnosis no matter what. So be aware that wherever that what we need to make sure that billing is aware of is that the primary diagnosis is the thing that drives where that bill goes to. Otherwise, and if you would have had like a 99213 with, let's say they were there for just hypertension and alcohol use disorder, and your primary billing code is alcohol use disorder, it would go to the fee for service. And if it would be a 99213 with just the AUD and a 99214 with the AUD plus the hypertension, you still bill the 99214. So you don't get like knocked down because you're doing your job. Which I've had that question come my way. So I know I could have asked Laura that question, but I knew that one. But that's one that kind of, and vice versa. If the primary diagnosis is diabetes, you'll get full reimbursement for what you do in that office visit. They don't like subtract out the one that's would if it was the only thing, go to the other entity.
Feel free to unmute if anyone else has a question. And if you haven't already, if you could post your email to Melissa in the chat. We definitely want to get the recording link out to everyone who's here today. I've gathered most people's email addresses, but there are a couple of folks, Craig and Ron, if you're on with us still and you want to post your email address to me, that way we'll make sure that you get the recording link and some documents that are kind of one-pagers that explain some of the things that we talked about today.
Thank you, Melissa. Any other last questions, maybe? Okay, if not, then we are going to just give you an update. What are the next steps? So again, reminder, and especially if you're a physician.
I'm sorry to interrupt. I do have a question. I'm glad I.
No, great. Go for it.
Okay.
No, yeah.
Thank you, Tim Gammons again. So one thing too, we have multiple prescribers, physicians and mid-levels, and multiple office locations. Excuse me. And okay, so one thing we've encountered is credentialing, especially with mid-level and doctors too. I mean, credentialing is just laboriously slow, and but Medicaid, anyway, what I'm asking is, let's say, okay, this is a scenario that's been problematic. A mid-level who's not credentialed, we'll just stick with Blue Cross Complete, sees a patient along with the doctor who's also credentialed, but who is credentialed with Blue Cross Complete. And then you send the super bill in, there's the billing provider, there's whoever signs the note. And then, so I guess what I'm asking is, would credentialing, if a mid-level or a doctor is not credentialed with a certain Medicaid HMO, and we are seeing them primary substance use disorder, so we're billing this under fee for service now because that's the primary diagnosis. Will credentialing impair our ability? Will the lack of credentialing impair our ability to get reimbursed?
So I will say, if you are billing it primary fee for service, then the requirement is to follow all of our provider enrollment policies and credentialing and all that with provider enrollment. So I do not even dare to go near what provider enrollment does, because they have a whole process of who they, who they enroll and all of that. So I am not qualified to make that. I would say provider enrollment is the one who would be most, that they're the ones that manage all of that. if you are billing us fee for service, it would be our specific, obviously we would be the primary payer then, so it would be our specific rules. So it would be what provider enrollment, what they require for that. So I cannot speak to that. I think that kind of goes into Laura rules and supervision and all of that as well. So I stay as far away from that as I can on the policy side. But definitely provider enrollment, they can definitely help you with that. If you're obviously billing us primary, then you would follow our primary payer rules and they can help you with those requirements.
Okay, thank you.
Thank you for putting that email up. Yep, provider enrollment at Michigan.gov. Thanks so much.
Okay, any other last minute questions? No. Okay, so what's upcoming next? And I encourage you to really send your billers to December 2nd from 10 to 11 a.m. Eastern Time. It's really how to handle billing, and we are happy that we will have like Nicole Salava with us. And we will send definitely recordings and links to this presentation along with the free one-pager explaining regarding this new policy and everything what we talked about today. And finally, after these two sessions, we will collect all of your questions and some other questions and develop a frequently asked question document and then share that with you all. And with that in mind, I want to really thank you all. Thank you all presenters. Thank you Opioid Response Network, and thank you Dr. Cara and Laura Kilfoyle for being with us today. And have a nice rest of the day.
Thank you.
Thank
Thank you
you
all so much.